Good afternoon. Appreciate y'all coming in and joining us after lunch. I'd like to say that if you feel the need to doze off, please do. I won't be offended at all. I'll try to not doze off while I'm talking, but I appreciate y'all's attendance here this afternoon. I was asked to talk a little bit about bovine surgery and a general state of the art in terms of where we are and where we're going and the things that we're doing. Livestock surgery is a little bit of an interesting ground to be practicing in because we have responsibilities that our companion animal colleagues don't necessarily feel pressures out regarding protecting the consumer and ensuring food safety and food quality, and that the things that we do don't adversely affect that. So we're kind of in an interesting position. We're very much affected by, let's see, got to be smarter than the technology. All right. If you turn it on, that works. And so, it's an interesting position that we get into because we have a lot of different responsibilities. We're trying to take the best care that we can of the animals under our stewardship. We're trying to respect the needs of our clients and allow them to have an animal that will meet their needs for their production business. And we're also trying to protect the consumer. And so we have a lot of different responsibilities. Our heritage goes back a long way. The veterinary profession was built on livestock and the need to support communities. And so our heritage goes back thousands of years. And there, in the history, in the archives, you can find references to surgery and livestock that go back thousands of years as well. There were certain landmark achievements as veterinary surgery progressed, and we're at the point now to where we're, really enjoying a technological expansion and being able to apply techniques in surgery that we haven't enjoyed in the past that certainly make things very professionally rewarding. And so I'll try to touch on a few different things. I'll ask for your indulgence and allow me to wax philosophical. I'm at the point in my career where it's difficult for me to talk for any extended period of time without talking about philosophy. And so I'll touch on a few things that we struggle with and things that we would like to do better, and some thoughts about that. So advancements in surgery go hand in hand with advancements in pain management and anesthesia. The better ability we have of providing a pain-free environment, it's better for the patient, it's safer for the surgeon, certainly it's safer for the assistants that are cooperating in those procedures. And so the more safely we're able to do procedures, the more effectively we're able to provide analgesia, the more efficient surgery we can perform, and generally the more successful surgery we can perform. And so those things have been going through some significant changes the last couple of decades, but we still enjoy the art of surgery. And so surgical art is built on a foundation of science, and so we have knowledge of anatomy and pharmacology and the tools that we use in surgery, the physiology of the animals, and then the various techniques that have been published and brought to you by surgeons who have had successes. And that's a tremendous advantage that we have, but it's still an art. We're still applying the information that we have through the lens of our experiences. And so there's not a standard of practice for things typically in livestock surgery. And so that's one of the things that's made congresses like this so important, is so that on an international level we can get together and talk about things and present new techniques for practicing our art. I think one of the things that has gotten a greater emphasis in recent times is outcome assessments. When I was in school, if we could perform a surgery on a cow and have the cow live, have the cow go home, have the client be satisfied and pay their bill, that was a tremendous success. We earned a living. They got a cow back that was able to be unloaded from their trailer. And we were thrilled about that, And so there's lots and lots and lots of literature where the endpoints for publication are discharged from the hospital. That's not saying very much, is it? And so outcomes assessment has become a bigger tool that we need to know what are we actually accomplishing. My practice goal might be to have the owner pay their bill and be satisfied, but if I'm not able to return that animal to a productive state, I haven't accomplished very much for that client, and so I might not be able to do very many more procedures for them. And so that's something I'll touch on periodically throughout the presentation, because outcomes assessment is a very important aspect of what we're doing now. Recently, evidence-based medicine has become a much bigger issue in veterinary medicine, and I think the application of outcomes assessments and a critical analysis of how those outcomes were determined is a big part of what we're trying to do now. We're trying to develop these evidence-based categories that allow us to determine how much emphasis we can put on the data that we're looking at and whether that truly represents an expected outcome for that procedure if you were to then do it in your practice. And there are many things that people are good at. I'm good at certain things, and you all each have your own areas of expertise that I wouldn't be good at. And so we know that the translation of knowledge from one surgeon to another isn't one-to-one. I can't describe a procedure to you and have you go do it and expect you to have the same outcome that I have. You might have a better outcome than I had. And so trying to set up studies that allow us to decrease the variability between surgeons and increase the expectation that when we do that surgical procedure, we're going to get the predicted outcome is an important part of evidence-based medicine. And so our experience is valuable. Our ingenuity in order to attack procedures that we may not have solutions to, or to change procedures for which we don't have the best solutions for. Our opinions factor into that. We each bring to the table a different perspective in how to accomplish tasks. But we need to do clinical studies, we need to do research studies in order to refine these techniques. And then ultimately we need to be able to measure them. And so clinical studies are an important part of that. A teacher of mine in veterinary school, as a young veterinary student, this was in my first year of veterinary school, and the teacher's up at the front, and I've worked for veterinarians for 10 years at this point as a veterinary assistant and doing things, and really felt like I had a pretty good understanding of what I was going to be doing in my future. And that professor said, experience is the greatest teacher, but it's the worst informed resource. Meaning that if our knowledge is limited to our own experiences, we have a limited ability to advance our expertise. And so we have to share knowledge, we have to share information, and we have to do so in a structured way that allows us to critically review those outcomes and see if they really match up with what we're seeing in different situations. We have limitations in bovine surgery, as everybody in this room is very well aware, and cost of care is one of the most important ones. There are lots of procedures that I would like to do in a very much more sophisticated way than I'm able to do them, but the client's not able to justify those expenses because of return on investment issues. And so we find other ways of doing things. I don't live in a black and white world, I live in a gray zone. And so if a client's not able to afford what we would like to do, we negotiate and find out what we're able to do. And very oftentimes we can come to a middle ground that allows us to correct the problem that the animal has in a humane manner and allow that animal to return to productivity. And oftentimes that expands our horizons more than if we were only doing things at this very top tier level, which is very enjoyable, but sometimes isn't possible. There are things that we have limitations on still: cardiothoracic surgery, neurological surgery, surgery for cancers, things like that are examples of ones where we're very limited clinically. And we lack certain standards of practice. And so there are things that are very common. Dental problems, actinomyces bovis, infections of the mandible, respiratory ailments that would benefit from surgical corrections, that we don't really know what the best options are because the frequency of intensive treatment is low enough to where we're not able to bring large cohorts of animals together. And so I enjoy walking through the poster halls and seeing many of those posters presenting large populations with outcomes data and treatment data that allows us to, or allows me to broaden my perspective on some of the things that we see. And so we would like to see more validation of surgery techniques. We would like to see more studies that are balanced and randomized and blinded and whatnot. But as you very well know, as veterinary surgeons, we're very protective of our clients, and we want to do the best job for that animal, and are oftentimes extremely reluctant to enroll them in a study where they might be put in a treatment group where we don't feel that that would give as good an outcome. And so those types of studies are very difficult to set up, and they're very time-consuming to set up, which is one of the reasons why there's so few of them. One of the other deficiencies in the literature regarding bovine surgery is time to follow-up. I mentioned that before, is that it used to be that we would categorize success as the ability to discharge the animal from the hospital. And then people started doing follow-up studies, and a lot of those studies showed that if the animal was discharged from the hospital, most likely it was going to remain in the herd and be a productive member of the herd. But one of the things I think we need to think about is setting some type of standard for definitions of short-term and long-term follow-up. In one paper that on dental disease, short-term follow-up is defined as discharge to the owner. Long-term follow-up is defined as doing well 30 days after discharge. Now, everybody in this room knows that 30 days after discharge for dental problems is not a long-term outcome. It's not even a short-term outcome. But they get published in the journals because the journals really don't have standards for looking at those things. In a human journal with implants, for example, if you have less than 5 years of follow-up, you're not even classified as short-term. And so, one of the things that we need to think about is what really would be those endpoints that would allow me to look at an owner and say, for this type of surgery and this type of correction, I would expect you to experience X with this animal. And perhaps short-term outcome is a 1-year production cycle where they finish a lactation, are able to get rebred, or able to enter into a second lactation. Maybe a long-term follow-up would be equivalent to the mean retention of animals in that herd. It should be considerably longer for a beef cow than it would be for a dairy cow. I don't know, but I know that those are conversations that would be worth having in the scientific literature aspect of things. So when I look at things that we do and things that we do differently in surgery, there are a couple of big things that come to mind for me, and one of them is pain management. So I'll talk a little bit about pain management and some of the different things that we're doing now, perhaps, and that we're trying to do with multimodal therapies at the time of surgery as well as postoperative management. And then I'll use 3 examples of advancements in surgical techniques that have pushed us, I think, as a scientific profession forward, but are still in the gray zone of whether that truly offers a better alternative to what we've been doing in the past. And I'll use abomasum and digit and teat surgeries as examples of those things, and the introduction of minimally invasive surgery. When I was in school, and I would look back at the veterinary profession in the United States and say that prior to the year 2000, the philosophy that we had for pain management was to monitor our patients, learn to recognize pain, and treat pain when it occurs. We've had a paradigm shift with that. And so now the dogma is predict pain, prevent pain, and then evaluate the effectiveness of pain management. And so if I think the procedure is going to be painful to the animal, or I expect it to be, then I'm going to use pain management prior to the experiencing of that pain. And that's a very logical thing to think about, but it's having important ramifications in the United States. A practitioner, I was a small animal practitioner, had their license suspended for 6 months because they failed to do preventive pain therapy on a dog that had a pelvic fracture. And so he looked at the dog and said, it seems okay, it's confined well in a stall, we're going to do surgery on Monday. Left it through the weekend without any pain management. They did surgery on Monday and everything went fine. The dog survived and he went home and the owners were happy he's catching a Frisbee. But they complained to the veterinary medical board because he didn't preempt the pain that the dog was experiencing, and he had his privileges to do surgery suspended for 6 months. That's a real thing. That actually happened. And so that's a paradigm shift. That's a big change from what I was taught in school and what I spent most of the first half of my career doing. Now, one of the things I like to do is surveys of our practitioners, because I want to know what's going on out in the field, because I don't know if I'm standing on ivory tower or ivory soap, or what we are doing in the universities and what we're teaching our students to do. Is that realistic, and is it in line with what's being done in the field? And so relative to pain management and surgical pain, I did a survey a number of years ago, and this is actually about 15 years ago, and so it's prior to that paradigm shift, or about the time the paradigm shift was happening in the U.S. And one of the things I was impressed with in this survey was that a lot of practitioners said that they were using paravertebral blocks for laparotomies in cattle. And paravertebral blocks was one of those things that we really struggled with in the veterinary school, because they can be difficult to do. Their efficacy can be marginal if you don't pay really close attention to how you're performing them. And we figured that was something that we were probably teaching our students, and then they would never do again after they graduated. And so over 20% of the practitioners reported that they were doing that. And from a pain management standpoint, theoretically, we have a larger zone of analgesia for laparotomies, and so we felt that was a good thing. The other thing I was really impressed with in this survey was that the practitioners told us that a large percentage of them, over 40% of them, were doing multimodal pain management at that time. And multimodal is a fancy label for talking about using a combination of anesthesia and sedation and other pain control drugs. So if you're sedating a cow with xylazine and doing a nerve block for surgery and giving them flunixin, you're doing multimodal pain management. And so multimodal is basically saying we're using different drugs with different mechanisms to complement each other to make it easier to do procedures. And so that, to me, I felt really good about that, because I felt like that was a high standard that a lot of people were achieving. The one thing that I think that we were really falling down on there, which I think is better today, is protocols. And so we'd go out and do a procedure on an animal, and that might be a DA or a C-section or digital surgery or whatever, and we would return the animal to the care of the owner, and we asked them if you had a protocol that you had in place with the owner relative to the pain management of the animal. And most of them answered that they were selective in that it wasn't consistent from procedure to procedure. They made a judgment call based on the individual animal. And the next most common answer was no. And so no was return the animal to the care of the owner, and don't do anything unless the owner calls you and says something's wrong. And so that's something where we have a great area for improvement. And we did ask what types of analgesics you were using in the perioperative period. And as you would imagine, most practitioners told us they were using non-steroidal anti-inflammatory drugs, flunixin meglumine being the most common because it's labeled for use in cattle in the U.S., and so we're restricted to that in many circumstances. Other generic non-steroidals, so aspirin and phenylbutazone and whatnot, were being used fairly commonly at that time. At that time of this survey, butorphanol was being used extremely commonly. This is before butorphanol became a controlled drug in the United States, so we were using that quite freely at that time. I think that would not be quite as common today, but it's still very common in practice. And then xylazine was the fourth most common one. And so those are very effective in different ways at providing some analgesia, and so those are things that we would expect to be very beneficial. We'll touch on those again later. And so the post-operative protocols are the one that I would look at and say, well, we've got a lot of room for improvement there, and so that's something that we could address. One of the things that I have struggled with as a pain management clinician is that I realize there's not very much I can do for an animal after it's dead, right? And so I can write a pathology report, and I can do a necropsy, and I can tell the owner why a better idea of why it died or why it had to be euthanized. So for me, for many, many years, I considered euthanasia to be a clinical failure. I've failed the patient, I've failed the client because I euthanized the animal. And so I was oftentimes guilty of allowing cattle that are in severe, unrelenting pain to go too long and too far before coming to that conclusion. And I will tell you now that I no longer consider it a failure. I consider it an appropriate treatment for these severe, uncontrollable pain situations. But I certainly have seen cattle and still see cattle that come into the clinic that and deep digital sepsis is probably the most common one that we know have been in intense pain on the farm for weeks, if not months. And they come into the clinic and they don't have any body fat left on them. They're so far deep in a hole in terms of being able to recover that we end up recommending euthanasia to the client as opposed to treatment. Now we have to make smart decisions when we're doing pain management, and different types of drugs are absorbed in different ways and with different half-lives and whatnot. We have to pay attention to the route of administration that we're using these drugs, and I'll go through some more specific examples of that. But butorphanol is one of those drugs that we sometimes use it IV, we sometimes use it subcutaneously, and we sometimes use it intravenously as part of a continuous infusion. And we know that when we're doing surgery, that our anesthesia crew will very oftentimes give them butorphanol IV as a way of decreasing the anesthetic load that they have to administer and providing some intraoperative analgesia. But we also know that intravenous butorphanol has an extremely short period of effectiveness. And so, if that's a route that we're going to go into and we see that we need pain management and we give them butorphanol intravenously and the animal feels a lot better, does it feel better long enough for us to walk away so that we can't look at the animal and now we feel better because we treated it and we can't see it anymore? If you stay and watch it, you know that those things are very short in duration, and so giving it by some other route, either subcutaneously where we might extend efficacy for a couple of hours, or as a continuous infusion in cattle that have very severe, very chronic pain that we're trying to control. We might do it on some type of a constant infusion on occasion. I talk mostly about drugs because that's what we do. Drugs and surgery are my main tools for pain management. I recognize that there are a lot of other modalities available, and we do have people in our practice that are certified in acupuncture and certified in chiropractic and rehabilitative medicine and whatnot, and we do use other tools to try to manage those cases, but I won't really go into any elaboration on those other modalities other than to acknowledge that they exist and that we do use them. I'm just certainly can't speak authoritatively about those techniques. So controlling pain during surgery or for surgical procedures. General anesthesia is something that we do more often at the university certainly than you do in practice, but still most of the surgeries that we perform are not done under general anesthesia. They're done under some type of regional anesthetic or local anesthetic. When we do laparotomies, we most oftentimes will do paravertebral anesthesia because it extends the zone of analgesia quite a bit into the abdomen. But one of the things that I'd always been frustrated over the years was we had a pretty good ability to administer localized anesthetic, whether that was the entire flank or just a line block or just the foot. And I always felt that we weren't necessarily doing the best job that we could. If we had a calf with a badly infected umbilicus or a cow that had a emphysematous calf and we were doing a ventral C-section or something along those lines, and we wanted something to supplement with that, with the local anesthetic, to increase the profoundness of pain control and increase the control of the animal themselves, but not increase the complication rate or risk during surgery of, say, the animal laying down or doing some untoward movement. And we'd always been very dissatisfied with the alpha-2 drugs because it seems like at the point where you gain that level of control over your patient, now it becomes very likely that they're going to lay down or you're going to have some other complication. And so one of the things that we started working on a number of years ago was this multimodal chemical restraint. And so we usually refer to this as CAT stun or K stun. We've been playing around with this particular protocol for over 10 years now. And this base protocol, which are the drug dosages that are up there, is still the one that we use the most commonly. And we've done research with this protocol, comparing it to some of the other protocols for pain management and surgery, and we've been able to demonstrate some level of superiority with stress responses and pain responses during surgery. But what we're doing with this program is just adding a narcotic and an alpha-2 agonist and a neuroleptic together at very, very low dosages. When I was in school, I was taught that ketamine had no analgesic benefit whatsoever. It was not useful as an analgesic, and now we know that it does, and it's an NMDH receptor antagonist, and ketamine is used in cancer victims to try to help control chronic severe pain of cancer, but at very low dosages. And so not only does it do these extremely low dosages allow the animal to remain standing, but it also induces something of a dissociative state without getting the untoward effects of some of those higher dosages. And it's also cost effective. Because these are very low doses, this is not something that's particularly expensive. And so we do that very oftentimes as a supplement for lidocaine and local anesthesia and whatnot. Now, one example, this is just one of our early data sets that we looked at, and we did over 100 laparotomies in cattle. We did 80 exploratories and 35 C-sections. And in that particular one, we gave the CAT stun prior to doing the local anesthesia, prior to doing the perivertebral blocks. And one of the things that we found that was the most helpful was the number of kicks and adverse responses during the perivertebral block were dramatically diminished, but in a way that those cows were completely in control and standing and whatnot, but were disassociated from what we were doing to a large degree. Of those 115 cows, 105 of them remained standing, but it's worth noting that 8 of those laid down before they got the ketamine stun. So not a drug-related effect, but a psychological effect on the part of the cows. Some of them were not very cooperative. The ones that did lay down after getting the K-stun were ones that have been repeatedly dosed. And so one of the things that we have found with this particular modality is that we don't tend to redose it very often, at least not at the full dosage rate, because you're more likely to cause the animal to lay down. So what am I trying to accomplish with that? You know, local anesthesia is effective to prevent surgical pain, but really only at the time of surgery. You know, local anesthetics are not generally used for extended pain management, and they're certainly not intended or not very effective at controlling distributive pain. And so some of these other drugs are very good complements to local anesthesia. And this has been borne out in the research. You know, there's a fairly large body of research on castration and dehorning and tail docking and small ruminants and things like that. And all of those studies have fairly consistently shown that when those procedures are performed with local anesthesia alone, there's a limited effect to that. And so by the time when the local anesthesia effect wears off, that the stress response comes back and all the untoward physiological consequences of surgical pain return. And so the non-steroidals are very quickly added on top of local anesthetics as a way of amplifying pain management in those cases. And most of the studies, not all, but most of the studies have shown a significant benefit of using non-steroidals in that post-operative period. And so if we go back to the paradigm of predict pain, prevent pain, and assess effectiveness, we know that there's a window of time, and that window might be 24 hours or 48 hours or 72 hours. There's a window of time based on the procedure that we're doing that we expect a pain response to be present. And so we like to select drugs that would have an extended effect during that window. And so I usually use a 72-hour window after surgery for my pain management programs, which influences some of the drugs that we're using now. So the classic drugs that we have the most experience with in the past are sodium salicylate, flunixin, ketoprofen, phenylbutazone, etidolac, and meloxicam. Etidolac you don't hear much about because it never really became affordable. We did some kinetic work with that in cattle, and one of the side effects of etidolac therapy in cattle is actually thrombocytopenia, so probably not the best preoperative drug to be using. But meloxicam certainly has become a mainstay of our perioperative pain management strategies. Phenylbutazone we've pretty much discontinued. It's with the other drugs that we have available, it's not really a very necessary drug, but we do have some bull studs in the state. In the states where stifle disease is an issue, and phenylbutazone oftentimes is the only drug that they can consistently get a response to for long-term pain management, but those bulls have sufficient value to where they're euthanized and buried on the farm, so they're not entered in the food chain. It is legal to use phenylbutazone in the United States if you're not a dairy cow 20 months of age or older, so in beef cattle we can still use that. Sodium salicylate, I worked with Hans Ketzer when we were both at Kansas State on some of the kinetics of aspirin, and was incredibly surprised to see the poor absorption of acetylsalicylic acid. So our big white boluses that we oftentimes used in dairy cows, and we found that it was very poorly absorbed, very poor serum concentrations, rapidly eliminated, and had a very minimal to no analgesic effect. So we've kind of dropped aspirin completely off of our treatment cart as far as perioperative pain management is concerned. So most oftentimes, if I'm doing a surgery that requires an acute extensive insult, so that usually would be a laparotomy or a cesarean section or a rheumaноtomy or something like that, fracture repair would be in that category, I most oftentimes will start the pain management strategy with flunixin meglumine because we give it intravenously. It's labeled for use in cattle. It has a rapid effect, and we've shown that to be a very effective perioperative analgesic. But we rapidly will convert over to the use of meloxicam because of the more favorable kinetics. And so we can get a much more prolonged period of analgesia using meloxicam than we can with most any of the other non-steroidals that we have at our disposal. But meloxicam has a limited potency. It doesn't overwhelm a lot of surgical pain, especially when we're doing surgery of the digit. And so we look at other drugs that might be complementary to meloxicam. And gabapentin is one of the ones that we have used very commonly with digital pain. And we have reported studies where we've shown that gabapentin administration can be effective at mitigating digital pain in cattle, especially when it's given in combination with meloxicam. And gabapentin in people is more oftentimes thought of a chronic administration drug that takes a period of time to build up to achieve its clinical effect. And I think that's probably true in chronic pain situations in cattle, but we do see an effect of gabapentin within a day or two of starting it. And so the dosages that we use are 10 to 15 milligrams per kilogram body weight once or twice a day. One of the things I'll tell you is that when we get up to that 15 milligram per kilogram dosing rate twice a day, we very oftentimes see cattle start getting listless and have increased lying times and decreased eating behaviors. And so we try to stay on the lower end of that dosing regime when we can. A new drug that just came out that I'm really excited about is Galliprant. And this drug is an EP4 receptor antagonist. So it gives us a different tool in pain management. So we have narcotics that we've talked about. We have alpha-2 agonists that xylazine is the most common one I use, and a lot of people use metatomadine and rimifidine and whatnot. We have the cyclooxygenase inhibitors, with the flunixin being the most common one that we use in our practice. We can also inhibit arachidonic acid release by giving steroids, and there are folks in the United States that use steroids in those intense cases for that. Galliprant provides us a mechanism of blocking the receptors, and so this is a drug that I'm really interested in doing some research with in multimodal pain management with these more severe cases, because now if we're unsuccessful at significantly obtunding the prostaglandin response in response to inflammation and pain, now we have an opportunity to block it at the receptor level, and the EP4 receptor is the one that's most intensely associated with pain stimuli. And so in my mind, those would be very complementary drugs. But it's labeled for use in dogs in the United States. It's come on the market very recently. And it's one of those drugs that we're hoping to do some kinetic work in livestock to find out whether it's applicable at all or not. And so that one, I think, is a drug on the horizon. So let's talk a little bit about surgical advances. And abomasal displacement in cattle is kind of the golden surgery in bovine surgery. It's the cruciate ligament of the bovine. And if you're a small animal surgeon, you can't finish your career without publishing a paper on cruciate ligament disease in dogs. In cattle, I think that that's sort of the way we look at it sometimes. We've all got to put out a paper on abomasum, and I don't feel good if I haven't published something in that space. And so there's a lot of papers on this and different techniques and approaches, which is great because that's the volume of data that we get is what we need for meta-analysis. And so it's been recognized frequently since the mid-portion of the 19th century, and sort of the progression in abomasal surgical clinical science was the recognition of the problem and what it was and to define it, and then to try to figure out how to diagnose it and how to recognize it in those clinical cases, and then figure out a treatment for it. So we identified it as a problem, we figured out how to diagnose it prior to necropsy, and then we spent a couple of decades developing a lot of different treatment for abomasal disease. Now we're sort of in the phase of figuring out all the things that cause it and contribute to it and how to prevent it. But so people are trying to put me out of business. But we're still really interested in ways of surgically correcting abomasal displacements. It's still a very common problem. We still see complications associated with all the techniques that we use. And so we're always trying to build a better mousetrap and figure out another way of dealing with these things. A lot of different types of abomasal displacements that have been recognized. The two on the bottom, maybe less so than any of the others, but we do see anterior displacements and interior displacements of the abomasum once in a while. A lot of different surgical techniques, both open surgical techniques and closed surgical techniques, and these have been used for a long time. And there's a lot of debate about which technique would be better. And I'll tell you, in the United States, it has a lot to do with where you went to school and what practitioner you went to work with when you got out of school. If you're in the Northeast, you're probably taught to do right paramedian abomasopexys. If you're in the middle section of the country, you're probably taught right flank standing omenopexys. And if you're in the West Coast, you're probably taught left flank abomasopexys. And it has everything to do with geography and relatively little to do with cattle. And so it's one of those things that this is an area when I talk to practitioners in the United States is I tell them never change your technique based on what anybody, especially me, says. Do what you're good at. But the only way you know what you're good at is by doing outcomes assessments. And so if you're doing abomasal corrections and you're not getting 90 to 95% of them back into production, you need to know why. And it may be because they've got such bad fatty liver disease on the farm that it's not an influence of the surgery. It may be that you're not particularly good at that technique. Find another one. And so it's all about self-analysis and being critical of ourselves. And so there are a few papers that have compared these techniques. Very oftentimes, it's hard to bring people together and say, well, you're excellent at right paramedian abomasopexy, so you do those. And I'm excellent at right flank omenopexy, so I'll do these, and then we'll compare them. Well, if we're excellent at those two procedures, we already know what the result of that paper is going to be. What we need to do is get me out of my comfort zone and see if I can replicate your results, and get you out of your comfort zone and see if you can replicate my results. And if we still both end up being excellent, then we've got a robust surgical technique that we can validate. But find what you're good at, keep doing it, no matter what anybody else says. All right. One of the things that we have struggled with in the States is blind suture abomasopexy, toggle pin techniques. Those became very popular because they're minimally invasive, they're quick, they're generally inexpensive as long as the cow does well. And there are a lot of people that have taught lay people to do them. And so some of the dairies will have people that are trained. And Dr. Sternert has done a very good job of saying that this is a technique that you can train someone to do who's not a veterinarian. And that's what one of the purposes of this paper was, is that, yeah, veterinarians do a really good job of toggle pinning, the roll and tack procedure. They do a very good job of laparotomies, but so can the herdsmen if they're trained properly. But we all know that one of the easy things about a technique, when it's closed and it's that easy to perform, it's also easy to do incorrectly. And I've taken toggle pins out of the reticulum and the omasum, and I've even taken toggle pins out of the uterus before when they were done by lay people, and that takes skill to put one in a uterus. And so one of those things that we get concerned about is on a focused scale, when you're looking at people that have a high level of training, this is a very, very good technique. But does that mean it should be applied to the general population? And sometimes economics drives us a little maybe too far in trying to find more cost-efficient ways of doing things. In our situation, we like to open cows up for a lot of different reasons. We think we do a better job, but also we're teaching students and we're giving them skills that they can then go build practices around in some manner. And so most of the outcome assessments that are in the literature don't show dramatic differences in these techniques, and I think the reason is because the people that are doing them are quite good at them. If I did a technique and I only had 30% success rate, I wouldn't publish it, all right? I don't want you to know that. And so the literature is kind of a hard thing to interpret sometimes because we don't like to expose our failures. And I'm guilty of that as much as anybody else. Laparoscopic abomasopexy was a really neat, interesting idea. It was a really neat technique that was developed to basically say, there are some real tangible advantages to minimally invasive surgery. We don't have to open the abdomen up, and therefore the convalescence rate should be a lot shorter. The risk of complications such as septic peritonitis should be less. And so there's some real tangible advantages to looking at those minimally invasive procedures. But can we do it more accurately? Can we do it more precisely? And one of the things that I like about these laparoscopic techniques is that now we're saying, okay, we're going to do minimally invasive surgery, but we're going to do it precisely so that we know where these toggle pins are going and that we can accurately place them. And there's a two-step technique that is done with the cow standing and then laying the cow down and retrieving the toggle pin suture. There's a one-step technique that there's a couple of papers on that is just rolling the cow up on their back and doing a ventral laparoscopy to be able to apply the toggle pin. That was something that when the two-step technique came out, we very quickly adapted it over to one-step technique because in my early years, I'd done a fair amount of laparoscopic surgery in cows, and I knew we could get to the abomasum accurately and place those toggles. And so there's a certain amount of professional reward to doing that because now I have something that's more elegant. If I can more precisely place those toggle pins, my complication rate should be lower on the whole, and therefore I can keep my hands in the game on those client farms rather than say a layperson taking over some of those procedures. Looking at different types of laparoscopic abomasopexy, there are some other techniques that have been developed, and the group at Montreal has spent a fair amount of time developing some suture techniques for abomasopexys. They give a broader and more firm adhesion that probably has better longevity, but it also takes a considerably more or longer period of time to be able to do it, and so sometimes that can get into problems. Just because of the duration. As I said before with some of the other techniques is when you look at comparative literature, most of the time they're pretty similar. People that are doing those procedures and reporting those are pretty good at what they do. Laparoscopic abomasopexy takes less time than amenopexys, and that's been reported. Should allow us to use less or fewer antibiotics, and actually when we do these, we use no antibiotics at all when we do them. Return to milk, we would expect them to be maybe a little bit more brisk as opposed to some of the other techniques. All right, and let me switch tracks here a little bit and go to digital surgery as another example of significant advancement in bovine surgery over the years. And traditionally, when we had deep sepsis in the digit, the only option I was taught in veterinary school was amputate the digit, and so we would take it off. And that seemed to be reasonably effective until some of the outcomes analyses started to come out. And I think most of the practitioners I talk to that do digit amputations fairly regularly would tell you that, those animals do fine. They get up, they walk off, they heal, they do well. But we're not following them far enough out in their production cycle to really know sometimes what happens with them. And this was a study that was one of the larger, earlier studies that was published, and this was out of Kansas State in the early 90s. And when they tracked those the cattle performance, they had 85 cases that they tracked out. They found that only about half of them returned to their prior level of production, so they were able to be maintained in whatever purpose they were doing. They had a mixture of dairy cows and beef calves and whatnot in that study. But they also found that there was that about 30% of that population were culled because of lameness within 7 months, after the procedure. And we've done some work to look at the interdigital ligaments that stabilize the fetlock and whatnot, and we think we know some of the reasons why amputations decompensate later on. But because of an increased realization of some of those outcomes that really aren't ideal, we go looking for other ways to deal with them. And certainly the procedures and techniques that were developed in Europe, we've adopted to a large degree in the United States. Took considerably longer period of time for us to figure out exactly how to apply these in different populations that we were looking at, but very, very common now. There's three main techniques that we look at for dealing with these distal interphalangeal joint infections. One of them is a proximal arthrotomy technique, and so Andre Desrochers published on this a while back, where we come in a proximal of the coronary band and clean out the joint. And then we have the plantar technique, which most of the literature is utilizing the plantar technique, and so we would very oftentimes do a deep flexor tendon resection associated with that and remove the navicular bone and clean out the joint. One of the things that we get concerned with those is chronic hyperextension of the distal interphalangeal joint associated with loss of the flexor tendon assembly. If they don't form a good solid bone union there, the toe oftentimes will tip up, and we have to do lifelong hoof trimming to try to address that. Another technique is this Abaxial approach, and in beef cattle practice, this is by far the most common approach that we use in the U.S., because in beef cattle practice in the U.S., we very rarely see complicated sole ulcers. The most common reason that we see distal interphalangeal joint infections is complications of foot rot or penetrating foreign bodies between the digits. So the flexor tendon array is fine, the navicular structure is fine, it's just the distal interphalangeal joint is compromised. And so we would use these windows through the hoof wall, either using drill bits or using Dremels to cut out windows to be able to address that. So the question comes down to is that did we make things better, by switching those techniques and keeping eight-toed cattle? Is that better than what we were doing with digit amputations? And we think that our clinical impression is that we did make them better. But I don't know that we have a clear enough set of data to truly say that. The Plantar method has been reported to be very successful in this particular case here. 83% returned to normal ambulation, despite the fact that only 60% of them actually achieved a bony ankylosis. And so the ankylosis is stable, sufficient for return to normal ambulation. In Dr. Desrochers' study, it was about 95% of those returned to their intended level of productivity. Some of the work out of Cornell has looked at comparing amputations and ankyloses, and in this particular case series, they reported that there was a significantly longer retention of those cows in the herd that had the ankylosis done and they did the digit amputation done. And the cows that had the ankylosis procedure, and they were using the Plantar approach, had higher milk production in the early period, the first 60 days after surgery, which I look at that and I've also oftentimes wondered with these procedures is, are we doing the most humane treatment? Because if I amputate the digit, I can get them pain-free much quicker. But if I've got good milk production, I take that as an indicator that we are treating these animals humanely. They are responding to the therapy reasonably well. But this was not a controlled study. It was the clinician's discretion as to which procedure was done. And so I like this study that Alex Starkey published, where they did a better job of controlling for those populations and which one was going to get an ankylosis versus an amputation, and had better matching to follow those cattle out. In that study, with the digit amputation cattle, about 1 in 4 suffered a companion claw injury, and as opposed to the ankylosis cow, whereas about 1 in 20. And so, that was a pretty big difference for me, and one that I felt better about in terms of comparing those two procedures and long-term results. The culling, because of lameness, was a little bit higher in the amputation cows, so almost 50% of the amputation cows were culled because of lameness, chronic lameness problems, as opposed to a third of the ankylosis cows. Those are the types of data that I really like to see and would like to see a lot more of in the literature. And I'll finish up by making some comments about teat surgery, because again, as a surgeon and someone who really enjoys spinning every day with a knife in my hand, these minimally invasive approaches are really interesting to me because the technological aspect of it, magnifying things, making things easier to see and touch and treat, are good. Our traditional approaches with teat surgery might have been to take cows that were poor milkers and treat them blindly, either with Lichty teat knives or Cornell tumor extractors or other types of corkscrew mechanisms to open up the teat. And then we evolved into thelotomy procedures where we open the side of the teat and deal with these masses and scar tissue formations and whatnot directly. And that was something that a lot of practitioners were really uncomfortable with. I don't know that it would be wrong to say a lot of academic surgeons are uncomfortable dealing with them because of fistula rates and other complications associated with those open surgeries. And so thheloscopy, the minimally invasive surgery of the teat, was a way for us to approach these things differently and in a much more satisfying way professionally, I think, for us. And so the benefits of theloscopy as opposed to thelotomy is we should be able to get those cows back to a normal milk flow more quickly. We should be able to do that with less postoperative manipulations and shorter hospitalization time. Ideally, we're talking about offering them a better longer-term prognosis with no increase in the incidence of mastitis. And so we're trying to achieve some fairly lofty goals there, but we also had a lot of room for improvement with these problems because they can be quite challenging. The other thing I like about theloscopy is the instrumentation is built for the field. A lot of times our students look at what we do in the hospital and they say, well, I'd never be able to do that in practice because I can't afford all that equipment. Thheloscopic equipment is relatively straightforward and relatively economical. Over the years, we've gotten most of our equipment from Dr. Fritz, although we also use the Stort's thelorectoscope system from time to time as well. But the ability to do diagnostic theloscopy and operative theloscopy without opening the teat, to me, is very attractive. And so this is just an image from an axial theloscopy where we've inserted the scope into the teat through the street canal, and allows us to do a diagnostic investigation of the teat and find out what affectations may be present. This is the one that I have to admit took me a while to get comfortable with, that you're going to do what? We're we're going to punch a hole in the side of the teat of this cow that's in milk, and we're not going to close it up. And so the lateral thheloscopy is extremely useful for dealing with scar tissue formation at the base of the teat cistern around the Furstenberg's rosette. And this is one of those techniques that I was very nervous about inserting the cannula through the wall of the teat. Had to have someone come in that was doing thheloscopy and show it to me so that I could understand that, yes, this is something that's not going to result in a teat fistula. And the reality is that we've almost never seen teat fistulas form as a result of putting these lateral access ports in there because of the angulation of the port, which is a distal interior to a proximal exterior orientation. The pressure of the milk and the milking mechanism tends to force them to close instead of to open. And so that technique has allowed us to do a lot more things than we used to be able to do, and it allows us to offer our clients something that, they had a very negative impression about. They didn't like the closed techniques because they knew that cow probably wasn't going to finish the lactation. They didn't like the open techniques because they knew that there was a significant risk of complications. This is something that has allowed us to get these cows back into milk, but not hand the client back problems that they have to deal with. And so they tend to be a little bit more accepting to be able to do those procedures. The thelorectoscope is a way of doing surgery through that single axial port without having to create a lateral port. And it's a cautery attachment that's built into the theloscope. And we use some of those. I don't tend to use those very much on the distal teat scar tissue. I tend to use them more if I've got a mid-cisternal mass. But because of the cautery, certainly requires an air medium to be able to do it as opposed to a liquid medium, which you can do either way. And so these are just examples. The image on the left there is a fibrosis that's obstructing the gland cistern from emptying into the teat cistern. And although we probably wouldn't be able to correct that with the theloscope, we can diagnose the problem very precisely and then offer a treatment plan to the client where we might go in and implant a stent in order to reestablish milk flow. And so this is just an example of going in and extracting some of the scar tissue around that distal teat cistern, removing the obstruction from milk outflow, and we get a pretty clean result on most of these. We can do them under direct visualization, under magnification, and so it allows us to do a much more discreet and elegant job than we might normally have otherwise. So with thheloscopy, the aftercare program that we typically use is still one that I learned from Dr. Gieshauser, and doing what is referred to as a 3x3 program, where on the day of surgery we would milk out the gland, insert a implant into the street canal, leave that in place for a few days, remove it, drain the gland out, evaluate the teat, and then reinsert that. And I had one of my Jersey clients when I was still up in Ohio, and we were doing this program, and he was very skeptical because he knew this cow was going to get mastitis and that it was going to turn into a wreck because we were leaving this teat obstructed for a while. This cow came back so strongly for him that he started bringing us a lot more teat surgeries because he'd never seen one return to milk that well and that fast. And it speaks really to our own, sometimes we have to overwhelm our own self-biases about what we think is going to happen. And that was a really difficult program for me to buy into, but once we did, we enjoyed the benefits of it. Outcomes measurements on these. So, professionally rewarding is one thing, but it's got to be economical and it's got to lead to a result that's better than what we started with. So, is thheloscopy better than thelotomy? We know that the literature suggests that there are good results that can be obtained with thheloscopic surgery. In this particular report, 6 months after surgery, these cows had returned to about 82% of their contralateral quarter production, which would be considered an excellent outcome. In other studies with thelorectoscopy, the resectoscopy, the ability to remove some of those masses and whatnot, through the axial approach without creating a lateral approach have resulted in very high success rates and higher success rates at retaining those cows in the herd so that they're not culled because of complications associated with that teat. There's a little bit of literature that's does a direct comparison of thelotomy versus thelloscopy, and so this is one of the larger studies on that, where they had 56 cows and had a reasonably balanced population at looking at those, and the thelloscopy cows had a shorter post-operative recovery, had fewer cases of mastitis, and came back to milk production better than the cows that had had the thelotomy incisions on. And I would tell you that from my own clinical bias, that's been our experience as well, is that this procedure has offered us a better, more elegant way of dealing with some of these teat injuries. And this is just a herd retention curve. The thin blue line, which is the bottom line, is the thelotomy cows, and the top red line is the thelloscopy cows, and it's just demonstrating that we've got a little bit better retention. It's not dramatic in a large magnitude way, but certainly significant for many of our clients. So how far have we come? You know, what are we doing in bovine surgery? It's been a long time since 539 BC, when the Code of Rules for veterinary type work were originally introduced. We've had tremendous advantages in understanding etiology and pathogenesis of problems. We've had tremendous advances in the ability to diagnose and treat problems. Maybe not quite as far along as we would like to be on prevention, but you know, my challenge would be that now is the time for us to start really looking at validation. So we have a good repertoire of techniques to be able to deal with some of these problems, but we need more work on validation. But we can't forget our client, and so if we can't maintain cost effectiveness of our services, we're not going to get adaptation or adoption by our clients. So we can't forget the clients. We can't forget the patient. We need to optimize pain management. Sometimes when we do some of these things, it changes those profiles for the better, but we need to keep looking at new ways of being able to control pain. And if we can accomplish those three things, including validation, then I feel like that's really rewarding to me, and that we're advancing the profession, and I feel like I have a role in groups like this. And so I'll be happy to answer any questions and quit apothesizing and philosophizing. Yeah.
Thank you very much, David, for this wonderful presentation. I'm sure there are a lot of questions from the audience. Yes, please. Just wait for the microphone.
Hi, sir. Jenny from Brazil. And do you have any different type of protocol to control pain before the surgery in animals having no chronic pain and with animals with acute pain?
Yeah, so protocols that we would approach surgery in cases that have acute pain versus cases that have chronic pain. Yeah, and so the thing I would say is that with acute pain, where we control the incidence and severity, so laparotomies and C-sections and things like that, typically what we would do is sedate the animal, very oftentimes with the ketamine stun, very low levels, so that, you know, if we want to keep the animal standing, and they say standing, and then do the local blocks, because that sedative protocol diminishes the adverse response that we see with the local block administration. And then we prefer to give them non-steroidal anti-inflammatory drugs before the surgery. So if we're castrations, dehorns, laparotomies, all of that, we prefer to give a non-steroidal prior to doing the surgery. I think one of the things that we used to do is we would do a surgery and we'd say, oh boy, that was harder than we thought it was going to be, or more severe, so now we'll give them a non-steroidal. By that time, all the pain mechanisms are ramped up, and it's much harder to push them down after they've been accelerated. And so we now will give the non-steroidal prior to surgery so that we can lessen that ramp up that occurs during the surgery. With chronic pain, if I know, so I've got a cow that comes in with a septic arthritis and perhaps a tenosynovitis or tenovaginitis, and they've been in pain for a while, then I'm more likely to go ahead and start that cow on the day of admission with a combination therapy of non-steroidals and gabapentin or something like that, some complementary protocol that I know is better for animals that have had sustained pain, as opposed to what we would typically do is give them non-steroidals, and then if they weren't responding, then we'd add gabapentin on top of it, and then if they weren't responding, we might put them on a CRI. On those cows that have had chronic pain, I start the gabapentin right at the outset. And so as we start treatment on those animals, and you get 2 or 3 days into the treatment, you know whether the gabapentin is going to be sufficient or not, and you can elevate up to something that maybe contains a narcotic or something else quicker. So you shorten that window. I'm not sure if that answers your question or not, but okay.
Yes, please.
Yeah, hi, Nathan from New Zealand. Just got a simple one about, I've only mainly just been using xylazine a lot, and with your XBK protocol, you don't make any change to your dosages with IM versus IV?
Yeah, so the question there is intravenous versus IM and the dosage that we use. You know, the dosages that we're using are pretty low, you know, and so you can certainly use it intravenously. But if I say, I look at the individual patient, if I've got a Holstein cow, all right, and is acclimated to people and acclimated to work being done around them frequently, I'll oftentimes cut those dosages in half. Whereas if I've got an Angus cow that I've pulled off the pasture that likes the taste of veterinarians, I'm going to go to the high end of that spectrum, and I'm more likely to give the Holstein cow an intramuscular injection. I'm more likely to give that Angus cow an intravenous injection. The other thing is whether you want to do the procedure standing or not, because there are certain procedures that we like to do recumbent. Emphysema in a C-section ventral midline laparotomy would be an example of that, or maybe an open arthrotomy when I don't have access to a tilt chute. And we'll give the full dose intravenously, and then put a casting rope on them, because that dose will make it much more easy for you to lay them down in the field. And so if you're using rope techniques to cast them in the field, that dosage regimen given intravenously is really effective at helping you do that. You know, we originally started messing around with this with rodeo bulls, because the rodeo bulls, a lot of times we were having to knock them out to do anything to them. I mean, completely anesthetize them. But then we get into problems when you're needing to do something every single day, is it's really tough to safely do that every single day. And so we actually originally started working with this protocol so that we could get rodeo bulls handleable in a chute. And so I really am impressed with the power of that combination. You can slide the scale up or down based on what cattle you're working with. The cattle that are more sensitive to xylazine, you can slide it down. Cattle that are calmer, you can slide it down. But I try to keep the ratio the same. And so there's 1 part butorphanol, 2 parts xylazine, 4 parts ketamine. I try to keep that ratio the same when I'm moving the scale.
There's another question there.
Just Chris McGrath from Ireland, just a quick one. What size drill bit do you use for your coffin joint surgery?
As big as I can fit. So the question was how big a drill bit do we use when we're doing that abaxial approach through the hoof wall? And I generally, in adult cattle anyway, I'm trying to create a window that's about 1 centimeter in diameter or more. And so we'll go up sometimes to a 2 centimeter window. Oftentimes it's 1 centimeter high and 2 centimeters broad on or parallel to the coronary line. I want to make sure that I've got adequate access to the distal interphalangeal joint to be able to clean it out and have it drain. And so I don't want to make a small defect that's going to fill in with blood clots or early granulation tissue or something like that. So we're making a pretty generous hole. I will put a walking block on the other foot so that I lessen the pressure that's on that toe. And we really haven't had a problem doing that. I mean, we do that in 1,000-kilo bulls. And we haven't had a problem with destabilizing those hoofs. You know, I worry initially about the hoof splitting out and getting vertical cracks and whatnot. And I worry about the losing the integrity of the capsule on the foot. But that really hasn't been an issue for us. So we can make pretty good sized holes.
And do you get to ablate the entire articular surface of the joint, or?
I don't think I would say that we are able to entirely remove the cartilage surface. I would say that on that abaxial approach, if I can get 60 to 70% of it, I'm really happy. You know, because you're limited in the angle that you can accomplish. The plantar approach gives you a much larger access to the joint, so you can do a better job of resecting it. But the abaxial approach is limited. Yeah.
We have time for one or two other questions.
All right.
Yes, please. Just wait for the microphone.
Hi, I'm Katharina from Germany. I was wondering, this abaxial approach, how do you determine the point where you put the hole in?
Yeah. So where do we locate
Yeah.
the window of access to the distal interphalangeal joint through the abaxial hoof wall? The landmarks that Paul Greeno worked, or he was the first person I heard describe that. Was if you look at the heel bulb and the dorsal hoof wall, about half the distance between that point should be close to the center point of the distal interphalangeal joint. And then if you look at the coronary band to the sole margin, if you come down about a third, you know that the intersection of those 2 points should be close to the ventral aspect of the distal interphalangeal joint, so the point of best drainage. And then you can expand it from there to remove as much cartilage as you can. With a septic joint, it's very easy to get into it. So if you're anywhere close in that area, you'll drop into it. If you're doing it on a cadaver foot that's normal to practice it, it can be much harder to find that sweet spot. And we actually find that in a lot of Holstein cattle, it's not a third of the way down; it's a quarter of the way down from the coronary band. What that ends up being is about 1 centimeter to 2 centimeters distal to the coronary band, and at the midpoint from the heel bulb to the dorsal hoof wall. And that you can use a smaller bit to explore that area, and feel comfortable that you're in the right area before you expand it. And we oftentimes do that. We'll use smaller bits initially and then enlarge it. But the other thing you can use is a Dremel tool, and to the side cutting tools that you can make a window out of the hoof wall. And I think you published on doing that, making windows in the abaxial hoof wall with that type of tool. And we do that as well. The most often times that I use the Dremel tool to make a rectangular window is when I'm going to take the navicular bone out. And the navicular bone is on that same aspect, but it's at about where the abaxial groove is. And so I'll just extend the window back to the abaxial groove, and then we can go in and remove the entire navicular bone that way. And in the cases where we do that, because the flexor tendon sheath and the flexor tendons are normally not affected in the beef cattle that we see, but it's not uncommon for the distal interphalangeal joint infection to extend into the navicular bursa or the navicular bone, is that if we feel like we need to resect the joint and the bone.
But without the tendons to be affected?
Without disrupting the tendons, yeah.
Okay.
And that way, if I've got an adult bull, I've got a 1,000-kilo Hereford bull, I can go in there and resect the distal interphalangeal joint, remove the navicular bone, leave the flexor tendons intact, and we feel like we get a much higher quality of arthrodesis of that joint and better longevity in those animals because they maintain the proper position of the toe. Yeah.
Thank you.
I think we have to move on. Thank you very much again.
You bet.
David.
My pleasure.